Hello friends, I am presenting a case of endometrial thickness of 18 mm in a 74-year-old postmenopausal woman with a stenosed cervix where pipelle was not able to do. So we planned for a hysteroscopy. So where we can see stenosed cervix, cervical canal could be opened only with the scissors. Only then we were able to negotiate the hysteroscopy into the uterine cavity to see a long tongue-shaped extension of endometrial polyp. I am Dr. Ravikant presenting a case of postmenopausal woman with a stenosed cervix and a thickened endometrium. This patient was attempted for endometrial pipelle due to thickened endometrium, but it was failed due to this stenosed and almost fibrosed cervix. External os of the cervix is completely fibrosed and unable to negotiate even a smallest diameter of uterine dilators into the cervical canal. So we planned her a diagnostic hysteroscopy to see why it was not able to pass the cervical dilators. So here we can see of complete fibrosis and obliteration of the external os. So we had to cut these fibers so that we can negotiate the telescope into the cervical canal and then see the what is the content of endometrial cavity, why there is a thickness of endometrial of 18 millimeter in a postmenopausal woman. As a patient was obese and we were worried about is it because of the endometrial malignancy. So we had to do diagnostic hysteroscopy to confirm what is the pathology in the uterine cavity. So after cutting these fibers, now we are able to see the cervical canal. So this is a external only fibrosis was seen only near the external os, and then we could able to see the now we are able to see the content. A small polyp like extension is seen through the cervical canal. Now we can slowly negotiate the telescope into the endometrial cavity to see the pathology that is seen in the endometrial cavity. Slowly we are allowing the cervical canal to distend and then negotiate the telescope slowly into the endometrial cavity. So now we can see the tongue-like extension up to the internal os from the anterior wall and fundus of the uterus. Some more fibrosis is still seen on the right side and the lateral wall of the cervix. So that is the polyp that can be seen arising from the anterior wall of the uterus near to the fundus. So once we are entering into the uterine cavity, now we can do polypectomy using a resectoscope. So slowly slicing the polyp millimeter by millimeter and then reducing the volume of the polyp. Later we can take the polyp from its base so that it does not recur, and we have to confirm this by histopathology so that we are not dealing with any malignant condition considering the age and body mass index of this patient. So usually for a stenosed cervix, it is better to go with the office hysteroscopy. But if we don't have a facility, we can do with the traditional hysteroscopy after cutting the fibers. Putting a misoprostol to 400 microgram in the vagina 3 hours prior to the procedure is helpful, so that it will efface the cervix and it will be helpful in negotiation of telescope into the uterine cavity. So with this we complete the procedure of removing the polyp after opening cervical canal by Caesar. So these are the final bits of polyps are being taken out from the base. So this we can see that the procedure is complete. We have removed the complete polyp and the whole of the uterine cavity is not showing any other pathology.